Well, what we have is a subject that is much too vast to be covered in just a few days of teaching. In fact, it would take years to cover the endocrine system and do it justice. Well, we have covered the hypothalamus in pretty good detail and its hormones. We've covered the pituitary gland in pretty good detail and its hormones. Uh, the truth be told, probably all cells of the body have secretions that would either be classified as endocrine or paracrine. So, truthfully, everything or every cell or every tissue probably has secretions that we could correctly classify as a hormone. Well, I don't have time to deal with all of them. So, what I'm doing is just making a list of some of the most commonly discussed hormones that originate from glands other than the hypothalamus and the pituitary gland. So on the next page, I have a chart that I prepared, just some hormones that came to mind, by no means exhaustive, but I will have quite a bit to say about these things. So I would once again advise you to get a notebook and get a pen and take notes because I will give you some details that simply can't be included in a chart, but the chart is a good summary and will help you to kind of sort things out. So on the next slide is just a chart of several hormones and their sources and effects. So take notes about what I say because I will test you over the things that I teach, whether they are listed in a table or not. Okay, next slide, Clyde. Since I have included in this table a column called polarity, then I need to say a few things about hormone chemistry so you will understand why I even took the time to list whether something be polar or nonpolar. Well, if you recall, polarity means an unequal distribution of charges. Something is more positive on one side, more negative on the other side, like we would have with water, a polar compound. If something is nonpolar, there's an equal distribution of charges, so the pluses and minuses kind of balance out to zero in the middle. So examples of nonpolar things are oils, or waxes, things that don't dissolve in water. Well, when we talk about hormones, we have two reasons why we need to know something about the polarity. Number one, the cell membranes are made of phospholipid and cholesterol. Those are nonpolar compounds. So the cell membranes are nonpolar. If we want to move something through a cell membrane, then that thing also needs to be nonpolar because the phospholipid bilayer will repel polar compounds. If our compound, in this case our hormone, is polar, then we would have receptor sites at the surface of the cell membrane for those, or perhaps we would have channels or pumps for moving through the cell membrane if the hormone is polar, because polar compounds would be repelled by the phospholipid bilayer. The second reason we need to know something about the hormone polarity is that these are transported in blood. The hormones go directly into the blood. Blood is mostly water. So blood plasma is like 92% water. Water is polar. So we have hormones that also are polar. That means they would dissolve readily in water, no problem transporting them in the blood. Well, if they are freely transported in the blood, dissolved in the water of the blood plasma, What that usually means is that they are easily eliminated from the blood by the kidneys. So they would have a short half-life in the body. So they're released into the blood, they dissolve in the water of the blood plasma. Well, they reach their target cells, all well and good, but they don't stay in the blood very long because the kidneys will eliminate it. If our hormone is nonpolar, that is an oily type thing that doesn't mix well with water, we have to have plasma proteins to transport those nonpolar compounds in the blood. Well, if something is bound to a plasma protein, it's not likely to be removed from the blood by the kidneys, at least very quickly. So they would have a longer half-life in the body because they are nonpolar. The nonpolars will bind to plasma proteins, and the plasma proteins are not eliminated by the kidneys. So this is why I have included a column about polarity, just to give me a reason to mention a little bit about hormone chemistry. Now, the non-polar hormones, that includes thyroid hormone, which we call thyroxine, sometimes called T4, sometimes called tetraiodothyronine. So that is a nonpolar substance. It is transported in the blood by a plasma protein called transthyretin. Remember, I said if it's nonpolar, then we're going to bind it to a plasma protein and it circulates in the blood bound to the protein. The other nonpolars are the steroid hormones. The steroid hormones are made by the adrenal cortex and also by the gonads. So that would include cortisol, that would include aldosterone, that would include testosterone, progesterone, estrogen. All of those are based upon or built from cholesterol. So they're called steroids. They are nonpolar and therefore they don't dissolve in the blood plasma. They are bound to plasma proteins such as albumin. In the case of cortisol, we have a particular protein that transports cortisol in the blood. It's simply called transcortin. So this is why I mentioned or why I listed a column here on polarity, because it does affect whether or not the hormone can pass through the cell membrane, and it also affects how it's transported in the blood. All right, so let's go through these one by one. I have a few things to say about each of these, which you might or might not find interesting. So the first one I have listed here, because I just kind of started at the head and worked my way down. Well, the pineal gland sits right in the middle of the brain. It is right above the corpora quadrigemini, right behind the corpus callosum. So it's right in the middle of the head. The hormone secreted by the pineal gland is melatonin. Melatonin is made from the amino acid tryptophan. The neurotransmitter serotonin is interconvertible with the hormone melatonin. So the two are both made from the amino acid tryptophan. We secrete melatonin at night, and it affects the suprachiasmatic nucleus of the hypothalamus. That's our circadian rhythm nucleus. So the observed effect of melatonin is drowsiness or the onset of, well, it's time to go to bed and go to sleep. Now, there are also some other things that seem to be affected by melatonin, and this was discovered by people who have a diseased or damaged pineal gland. Well, if that's the case, then they may not make melatonin. It has been observed that boys who don't have a pineal gland and therefore don't make melatonin undergo precocious puberty. That is a very strange connection. I don't know if anybody really understands how that connection is, but what it says is that melatonin, the hormone, obviously has effects other than just sleep onset. So for that reason, it might not be altogether wise to take melatonin supplements just to help you get to sleep, because there is evidence to indicate that melatonin does more than just that. Okay, enough said about melatonin. Let's move down. The thymus gland is located just above the heart, behind the sternum, and just above the heart at the location where the aorta arches over. In an infant and in a child, the thymus gland is very large. It may extend all the way from the area of the heart all the way up to the hyoid bone. It's very large and it's very active in an infant and child. It begins to undergo involution in the years of pubescence. So age 13, 14, 15, it begins to shrink up. As a person matures into adulthood, it's very difficult to even find a thymus gland in an adult. So it undergoes involution with age. Well, there's a reason for that. So notice what the target is here. The hormone, there are actually three hormones. I've only listed one: thymosin, thymulin, and thymopoietin are all three hormones of the thymus gland, and their target is T lymphocytes. Lymphocytes are part of our immune system. These lymphocytes are born and raised and educated in the thymus gland, and those hormones participate in that development and maturation and education of those lymphocytes. So the thymus gland makes thymosin, thymulin, thymopoietin. Those hormones contribute to the development of the T lymphocytes. Now, as it oftentimes is, the way you can see the importance of something is when it isn't there. Some people are born without a thymus gland, or they have an underdeveloped thymus gland. Therefore, they don't secrete those hormones in appropriate amounts. That is called DiGeorge syndrome. A person with thymic aplasia, they don't have a thymus gland, they're not going to have an immune system either. So they are at risk of any cancer, they are at risk of any viral infection, they are at risk of any infection as soon as they're born. They might very well have to be kept in a bubble depending on how much of a thymus gland they actually have. All right, let's go to the next one, thyroxine. That is made from two molecules of tyrosine. Since the two molecules are laid out 180 degrees from each other, this is how thyroxine becomes nonpolar. It's two amino acids bound together, so the distribution of charges breaks equal in the middle. So it is a nonpolar compound. All right, you did the PhysioX exercise, or you should be doing it soon, where you experimented with the effect of thyroid hormone. The target for thyroid hormone is all the cells of the body which have a nucleus and mitochondria. Well, that would not include red blood cells. They don't have a nucleus or a mitochondria. but all the other cells of the body do. So when we when we release thyroxine into the blood, then the receptor sites are in the mitochondria and in the nucleus of the cells. The effect of thyroxine on cells is to increase their rate of burning glucose. Well, we use oxygen to burn glucose, so that's the same thing as saying, well, it increases the amount of oxygen used. It increases the amount of glucose used. It increases the amount of energy produced. It increases the amount of heat produced. So we just call that an increased basal metabolic rate. Now that can be illustrated by, say, a car. A car burns gasoline. Well, cars have an idling rate. If the thing is just sitting in park, it should be idling at maybe 800 RPM, something like that. Well, what if your car is idling at 5,000 RPM? Well, then it's going to burn more gasoline. It's going to require more oxygen. It's going to generate more heat. That's the same way the cells do. We burn glucose in the mitochondria of the cells. Well, that gives us our ATP, but it also gives us heat. So thyroxine then is the hormone that regulates our basal metabolic rate. Now, the way that we see the importance of this is, what if a person hypersecretes thyroxine? They have an overly active thyroid gland. So they're dumping too much thyroxine into the blood. They are not going to be able to sleep. They're going to lose weight even though they eat everything in the refrigerator. They are hot even in a cold room. They are nervous and jittery and keyed up, and their eyeballs will bug right out the sockets. Man, that's called a thyrotoxic storm, typical of Graves' disease. So when the thyroid gland is over secreting thyroid hormone, then you get an increase in BMR. Now, just the opposite. What if a person has a hyposecretion of thyroxine? Well, they're going to be tired, sluggish, sleepy. They gain weight even though they only eat a can of cat food each day. They are very tired and they're very cold even in a hot room. So they are underproducing thyroid hormone. Their cells are not burning glucose very fast. They're not generating much energy. They're not generating much heat. That condition is called myxedema. Now, there is one other concern. What if the thyroid gland is not producing sufficient thyroxine in the developing fetus? Myxedema is a condition of adults. If it's in a fetus, it's called cretinism. Well, a fetus is busy about building bones and muscles and brain tissue and things of that sort. It turns out that an appropriate production of thyroid hormone is necessary for proper embryologic and fetal development. So if the developing fetus is underproducing or hyposecreting thyroxine, then the child will be born with cretinism, uh, profound mental retardation, and profound musculoskeletal retardation that goes with cretinism. Okay, the next hormone there is calcitonin. I mentioned to you when I showed you the histology of the thyroid gland, those cells that are called parafollicular cells or C cells. Well, they secrete a hormone called calcitonin. Calcitonin is available, it's abundant in children. You would be hard pressed to find calcitonin in an adult. Well, look at the reason why. Children are the ones who are growing bones. By the time a person passes age 20, their bones don't grow that much more. So the effect of calcitonin is to stimulate osteoblastic activity, therefore deposit calcium and phosphate salts into the bone to increase bone mass. Well, children are the ones who are increasing bone mass, so it's in children that you would find calcitonin. You don't find much of that in an adult. All right, just behind or on the back side of the thyroid glands, there are usually four parathyroid glands. Some people have parathyroid glands that may be anywhere from the area of the hyoid bone all the way down to the heart. Those are called ectopic parathyroid glands. Most people have four little islands of parathyroid tissue on the backside of the thyroid gland. All right, when we release parathyroid hormone, it stimulates the osteoclastic activity to break down bone tissue for the purpose of releasing the calcium to the blood. If a person does not have parathyroid glands, due to injury, disease, or surgical mistake, or they're born with hypoparathyroidism, then the problem they're going to have is maintaining blood calcium levels. So the blood calcium level goes down without the parathyroid hormone, and the effect of that will be tetany. The muscles go into contraction, they can't relax, the person will not be able to breathe. All right, from the heart, we have a hormone released called atrial natriuretic peptide. Natri means sodium. Uretic means PP. So the heart is sensitive to blood pressure. If the blood pressure is high, it presses against the walls of the heart. When that happens, the heart will release ANP, which says, get rid of some sodium. So the effect here is on the kidney tubules. And what we're going to do is eliminate sodium from the blood, because where sodium goes, water follows. If you eliminate sodium, the water will go with the sodium. If you eliminate the water, you lower the blood volume, consequently lower the blood pressure. That's why the heart releases ANP, because the walls of the heart are stretched by the increased blood pressure. So we eliminate sodium, we eliminate water, and we lower the blood pressure. Angiotensin 2 is the get it done hormone for managing our blood pressure. Angiotensin 2 is made by the lungs, and it's the target there are the arterial walls, and the effect is systemic vasoconstriction. So if our blood pressure goes down too low and the brain is not being perfused with blood, then we release angio2, the artery walls constrict, and that drives the blood pressure up. Otherwise, you're going to faint. So we release angio2 to manage the blood pressure by vasoconstriction. Erythropoietin is made by both the kidneys and the liver. I've listed the kidneys here because the kidneys make most of the erythropoietin. The target there is the bone marrow, and the result is we're going to increase our number of red blood cells. So if you go to a mountaintop, go to Denver, Colorado, or Mexico City, or Kilimanjaro, you're going to find less oxygen in the air in those places. Well, if you have less oxygen, then you better have more red blood cells. Otherwise, you're going to faint due to the hypoxia. So the effect of erythropoietin is to increase the red blood cell production by the bone marrow. Now, athletes have abused this. If you take erythropoietin as a medicinal supplement, it increases the red blood cell count, therefore increases the oxygen carrying capacity, therefore gives you an edge in running that 1,500 meters or riding that bicycle for 7,500 miles, whatever. So it is a performance enhancing drug and therefore has been outlawed for some anyway. All right, the next hormone there is calcitriol, also made by the kidneys. Calcitriol is the get it done hormone for managing blood calcium levels. We cannot have a drop in blood calcium levels. So if that happens, calcitriol is released by the kidneys, which will prompt the intestines to absorb more calcium from the diet and also release calcium from the bones so that the blood gets the calcium that it must have. Calcium is necessary for proper muscle contraction. Calcium is necessary for proper nervous system transmission of action potentials, and calcium is necessary for blood coagulation. So we can't have a drop in blood calcium. So if the calcium level goes down, then we release calcitriol, we release parathyroid hormone to get the calcium level back up. Otherwise, we're going to go into tetany. The next hormone made by the zona fasciculata, the neighborhood of little threads, that is the adrenal cortex. So our hormone is called cortisol. The target for cortisol is primarily the liver and kidneys, and the idea here is to conserve our glucose. So what we will do is burn fatty acids, and we will even burn proteins to conserve our glucose. We will also break down glycogen in the liver so that the blood has more glucose. The kidneys will perform gluconeogenesis. They will make glucose from other compounds. So the whole idea here is to conserve and increase the levels of glucose. So if a person is hyper secreting cortisol, then they are going to have a condition called steroid diabetes. Their blood glucose level is way too high. There's much more to be said about cortisol, but I don't really have time for all that, so let's move on. From the zona glomerulosa, the neighborhood of little balls, the outermost rim of the adrenal cortex, our hormone there is aldosterone. The target for that is the kidney tubules, and what we want to do here is conserve sodium. If we conserve sodium, then water goes where the sodium goes. We keep the sodium in the blood, therefore we keep the water in the blood, therefore the blood pressure doesn't plummet. So aldosterone is one of the ways that we maintain our blood pressure by conserving sodium, therefore water, therefore blood volume, therefore blood pressure. From the zona reticularis, the innermost neighborhood of the adrenal cortex, this is where we get those adrenal androgens. Androgens are things which cause masculinity. The hormone that's released from the zona reticularis is a precursor of testosterone. It's called DHEA, that is dehydroepiandrosterone. It will be converted to testosterone. Now, both males and females have adrenal glands, so both males and females make DHEA. So if we have an oversecretion, a hypersecretion of DHEA in the female adrenal glands, uh, you know, that's a woman who's got a pretty nice set of sideburns growing there, and her voice is deep like a man's voice. Well, she takes on the masculinization that goes with androgenic compounds such as testosterone being in the blood. So DHEA is a precursor of testosterone. It might also be of interest to you to know that it is testosterone that is the hormone of the libido. Since girls do not have testicles, then this is their only source of testosterone, the hormone of libido. If you don't know what libido is, look it up. My mama told me not to talk about stuff like that. Okay, let's move to the adrenal medulla. We have several things released from the adrenal medulla, primarily the hormone epinephrine. You know the effect of epinephrine. You have experienced it. The blood pressure goes up, the heart rate goes up, the breathing volume goes up, the pupils dilate, the mouth goes dry. That is the fight or flight response, which we call the sympathetic effect. All right, down to the pancreas. The pancreas are located just behind the stomach and duodenum. There are endocrine islets. They're called islets of Langerhans. The beta cells of the islets of Langerhans release insulin into the blood. Insulin enables cells to take up glucose. Well, cells have to have glucose as an energy source, so it is the insulin that enables the cells to take up the glucose. If a person has diabetes mellitus, then they do not produce insulin. Consequently, their cells cannot take up glucose. Consequently, the glucose level in the blood just goes up and up and up and up. So they have hyperglycemia, excessive glucose in the blood. Once you get enough glucose in the blood, it begins to spill over into the urine. So they have glycosuria. They have glucose in the urine. Well, there are lots of problems that go with having diabetes mellitus. That is the world's #1 metabolic disorder. It is also the #1 cause of blindness in America, #1 cause of limb amputation, etc. So you know all about diabetes mellitus. The alpha cells of the pancreas produce glucagon. Insulin and glucagon sit on a seesaw with each other. So we release glucagon into the blood between meals. So when we haven't eaten for 3 or 4 hours, our blood glucose level begins to go down. So we release glucagon, which stimulates the liver to break down its glycogen into glucose. Therefore, the glucose is available to the blood. So we release glucagon between meals. We release insulin after a meal so that the cells can take up the glucose. We release glucagon between meals when we don't have any glucose. Well, we get the liver to offer us some glucose by breaking down its glycogen. Also, I'm sorry, it's not an also. I mentioned earlier insulin-like growth factor that is released by the liver, stimulated by growth hormone coming from the adenohypophysis. This is our longer lasting growth stimulant. So the true bone growth, muscle growth, cartilage growth, all of that we experience in our growing years is primarily due to insulin-like growth factor released by the liver. Also, the liver releases hepcidin. The target there is the intestines, and the purpose is to increase iron absorption from the diet. Well, we eat things that contain iron, but iron is poorly absorbed into the blood unless we have the hormone hepcidin. Well, we have to have iron. Iron is necessary for hemoglobin synthesis. So we make 2.5 million red blood cells per second. They all have to be chock full of hemoglobin, and hemoglobin contains iron. So we have to have iron. We take it in by way of the diet, but we don't absorb it very well unless the liver releases hepcidin. All right, down to the next guy there, ghrelin, that is released by the parietal cells of the stomach when the stomach is empty. So if the stomach is empty, that says, I tell you what, we need to get something to eat here. Well, that is a hypothalamic function. So the ghrelin released by the stomach binds to the arcuate nucleus of the hypothalamus to stimulate the appetite. So the appetite starts saying, hey man, go get yourself a taco, get yourself some corn dogs. Let's go for, you want fries with that or onion rings? Well, give me both. So it's an appetite stimulating hormone released by an empty stomach. A little bit farther south there, the duodenum releases cholecystokinin, which has several effects. The hormonal effect that we're talking about here is when the cholecystokinin binds to the arcuate nucleus of the hypothalamus to say, that's enough. 30 corn dogs ought to be enough there, Clyde. Stop. You've had enough. So that's called satiety. I'm full. I'm going to stop eating. Fat cells or adipose cells release leptin, which also bind at the hypothalamus to say, we've got enough fat, so you need to stop eating so much. Well, what if a person doesn't produce leptin? Well, then they don't really have a shut-off for eating, and they just continue to eat. It's called hyperphagia. They eat and they never feel full. Well, they end up weighing 500 or 600 pounds. So leptin is the body's way of communicating to the hypothalamus that, hey, you've had enough to eat, you need to stop eating. So it is a satiety hormone also. Okay, we have a placenta that forms at about 6 weeks of development. Uh, the placenta releases both progesterone and estrogen to maintain the, the pregnancy, but also to stop the mother's production of gonadotropin releasing hormone. So while she is pregnant, she doesn't need to have a monthly cycle. Well, the monthly cycle that the woman has is initiated by GnRH from the hypothalamus. So the whole idea here is to feed back to the hypothalamus to inhibit the release of gonadotropin releasing hormone during the months of pregnancy. And our very last one here, released by the pre-embryo. This is the developing morula and blastocyst before it even implants into the wall of the uterus. It releases a hormone which is taken up into the mother's blood. So the pre-embryo makes a hormone that is taken up into the mother's blood. How do we know that? We can find it in the mother's urine. And the only place it comes from is a pre-embryo. So the hormone is called human chorionic gonadotropin, HCG. It stimulates the mother's corpus luteum. Keep making the progesterone. If the progesterone level falls, the pregnancy fails. So it is at this point that the pre-embryo and the embryo are releasing the hormone that stimulates the mother's corpus luteum to produce more progesterone. Otherwise, everything is going to fall out, including Junior. All right. Well, there are many others I could talk about, but I don't see where we really have time to do all that. So do what you can with these hormones and also the hypothalamic and pituitary hormones. And I will have to move along to our next chapter, which is about blood.